Hello and welcome to this commentary on immunotherapy side effects and the need for multidisciplinary care. My name is Fatima Cardoso. I'm a medical oncologist. I'm based in Lisbon, Portugal, and I'm joined by my friends and colleagues, Dr. Hope Rugo, Dr. Rebecca Dent, Dr. Zoe Quandt, and I will ask each of you to please give just a short introduction of yourself.
I'm Hope Rugo. I'm a breast medical oncologist at the University of California, San Francisco's Comprehensive Cancer Center, and I'm very interested in immunotherapy as a treatment, but also in identification and management of toxicity, and have focused at least some of my interests in this area.
My name is Rebecca Dent, and I'm thrilled to be on this panel. I'm a medical oncologist at the National Cancer Center Singapore, and also chair of Division of Medical Oncology. I have a great interest in triple negative breast cancer, so hence we've been experimenting, we'll say, with immunotherapy for almost a decade. So really excited to share some of our experiences today.
My name is Zoe Quandt. I'm also at University of California, San Francisco. I'm an endocrinologist with a focus in oncoendocrinology and a physician scientist. I'm excited to be joining you all to talk more about the endocrine side effects of immunotherapy.
Thank you. I think we will just start with addressing this need for multidisciplinary care. And perhaps I will ask your experience on how much did you have to reorganize care for breast cancer patients since you started using immunotherapy? As here in our institution is we just start using immunotherapy about 1-2 years for breast cancer. And that meant to reorganize the care for these patients regarding support from other specialties. So, Rebecca, what happened in Singapore when you start using, since you have many more years of experience?
Well, actually, my experience goes back about 15 years. I was a melanoma doctor in my other life in Canada. And so we first started using even combination immuno. And so I got very used to being a little bit more proactive and worried about patients because the side effects we see are a lot different than we see with chemotherapy. When I moved to Singapore and we started using immune checkpoint inhibition in clinical trials, one of the things that one of my colleagues did was get some of our juniors very quickly to sort of identify specialists, endocrinologists, GI, skin, all of the sort of known endocrinologists, of course, being first and foremost, identifying someone, maybe mid-career who was really interested and could engage and help us, because the problems that we saw were very unique. They weren't typical problems. And so we had to work, and we continue to work very closely to try and tease out, try to distinguish how much is potentially a toxicity from chemo versus the cancer versus immunotherapy. And I would say the time interval is so different than what we're used to using or what we're looking at, that we were really learning together. And I think, an open dialogue, continued discussion over WhatsApp, monitoring people's symptoms, knowing how to taper, let's say steroids, learning how to diagnose, how to just identify the toxicity, treat the toxicity, monitor it over time, and then decide whether to re-challenge. So it's not a one-time engagement, it's an ongoing relationship that, to be honest, for the most part, we aren't used to kind of having that. And I think both have found it quite fruitful and really critical to helping manage patients. Now, some of my colleagues in private, don't have the same access to multidisciplinary care within one center, but similarly have identified their key specialists. They're just used to collaborating with it. I think that makes all the difference.
Hope and Zoe, since you are working in the same institution, your experience?
Yeah, and it's great that we were able to include Zoe for her comments here, because that's what's so important for us. I think we're used to talking to our consultants about getting a biopsy or complications of cancer, but in this situation, we really needed to have urgent communication with specialists who we might not have previously needed to have that direct line with. And then we needed to understand who was interested in this area, who had experience with it, and who would be able to give us information about getting the testing and then see the patient in a fairly rapid time period. And what was interesting for me was, the first patient I had who had significant immune toxicity had colitis, and this developed almost 4 months after her last of 2 doses of a checkpoint inhibitor. And we really didn't recognize that this was many years ago. And it was really a lesson, I think, for me about the importance of being able to have everybody in the team, in my team, so the breast cancer docs and the nurses and the triage nurses, be aware of the risks, and then being able to immediately connect with a specialist, even for blind biopsies, for how to diagnose adrenal insufficiency. I mean, people really still don't really understand that on the oncology side, so we need to reach out to our specialists. So we really have developed a team of people that we can connect with. Mostly, I would say GI is still the largest challenge, but some of the rare toxicities, we maybe don't have as good a connection, but we can always find somebody rapidly who can see the patient. And this is really important. But on our end, we have to also have a very high degree of suspicion so that we know when we should be reaching out. Zoe, well, your experience in this has been, on the becoming our sort of right-hand person for the diagnosis and management of endocrine toxicities. And at UCSF, that was really a new function when you came to join us.
Yeah, I think as a specialist, people go into endocrine because there's no emergencies, but with checkpoint inhibitors, that's almost changed, right? Like we have to see patients a lot faster because the diseases progress a lot faster. So I think that's one piece that like having the experience really helps with being able to monitor things in a different way than we traditionally do as endocrinologists. And then I think the other thing that's really helpful in that almost every patient I see is on immunotherapy regimen. I'm used to the drugs. I'm used to the kind of knowing what's happening for the patients from the cancer perspective. And I, of course, always defer to the oncologist, but I have that familiarity with what is going on with them with the rest of their lives. And so I think that adds a lot to their care.
Now that you mentioned the monitoring, I think that's something that still people get a little bit, I wouldn't say confused, but not yet fully understanding what has to be monitored intensively, what can be monitored less intensively. And there are guidelines, of course, there are FASCO, ESMO guidelines, but any quick indication for those who are listening in terms of what you consider that is like mandatory in terms of before starting immunotherapy, immune checkpoint inhibitors, and while on the therapy from your part, the endocrine part?
Yeah, so for the 3 main toxicities that we see are thyroid, which happens a lot of the time. And there, I think most people will measure thyroid function tests with each infusion. Sometimes people will do it with every other infusion, and depending on the distance between the infusions, that can be okay. But the second you see anything abnormal, making sure that they go to every infusion. If they're on 6-week intervals, having something in between those 2 tests or those 2 infusions is important. We really want to try to catch people when the free T4 has fallen and the TSH lags. And so sometimes that will not be elevated yet, and we still have an interval of time to start therapy before someone's actually become overtly hypothyroid. For diabetes, which is super rare, I think we think it's probably less than 1% of the time in breast cancer patients. And there, I love having an A1C before someone starts therapy, and then glucose with each set of labs is all that we really ask for. Adrenal insufficiency, I think depending on the trial that we're working on, we sometimes with I-SPY actually check very frequently. In the practice that we have in other settings, it's less frequent, and as we mentioned, it's one of the harder ones to diagnose, and I can talk a little bit about that. But I think at a minimum, any sort of symptoms that can be related to adrenal insufficiency. So we're thinking about fatigue, loss of appetite, joint aches and pains, muscle aches and pains, nausea. Those are all like red flags in my mind that we should proceed with some sort of adrenal insufficiency diagnostic testing. And then I think the other thing that's particular to the breast cancer population that we're treating is we often are giving immunotherapy before going to surgery. And so really thinking about whether we need HPA axis testing before surgery, which is going to be thought of as a very stressful event and can actually induce an adrenal crisis.
We've treated a lot of neoadjuvant patients over the last 5 or more years, part of Keynote 173, Keynote 355, and now on practice, as well as some other preoperative studies for ER-positive breast cancer. And it seems like a lot of work to do the TSHs every cycle and do the adrenal insufficiency workup. But to be honest, I think it's really important in these curative patients going for surgery. I also have made a habit of calling the anesthetist and the surgeon, reminding them that patients on immunotherapy, should they have any issues with blood pressure management post-op, because they sometimes think I'm crazy, but I think having seen some of these toxicities at other sites and how scary this can be, I don't think it takes much just to say, hey, just letting you know the patient's on immunotherapy, this is something you should look out for, because you're not going to be around when they're post-op at night or something happens. And so this is rare, but this is quite significant. So this is just one thing for me going for op, that patients have this done. I think the thing about the thyroid too is that it can happen just any time, and everybody's course of thyroid dysfunction, I've learned it just takes some experience seeing a lot of these patients, and over time, like some fizzle out slowly, some get worse very quickly, and I don't think we can predict for which of those patients it is. So we just have to learn to get used to it and connect with you so that you can keep on top of it, as you said.
No, and I think that one there are several important points about this. I think one fascinating patient that we had recently that Zoe and I shared was a woman who was on our I-SPY 2 neoadjuvant trial using a checkpoint inhibitor along with an antibody drug conjugate, and the patient was using a steroid mouthwash, which she dutifully started 3 days before her first infusion. And her cortisol came back sort of halfway through at less than 1. And so I went back, and actually her first cortisol level was really low. And, it was like 2 or something, which, is very unusual for most patients. And it turned out that even though she swears that she was not swallowing the steroid mouthwash, that something funny was going on, because when we re-talked about it, reduced the frequency that she was using it, and she's the only person I've ever seen like that, her cortisol came back. But, it was really helpful because we did a cortisone stim, and although she didn't stimulate normally, she did stimulate. And, it's just fascinating to see that you can really misdiagnose these things and then commit people to lifelong steroids, and really a big management difference that doesn't exist. On the other hand, I had one of my patients who went back to her HMO, her health maintenance organization hospital, for her surgery. And because we mandate that patients have a cortisol before surgery, she had her cortisol 2 weeks before surgery, and it was, less than 1. And she really does have adrenal insufficiency. She went to endocrinology. When I saw her post-op, thankfully with the PCR, she said, and it was so funny, after that last cycle of chemotherapy, which was paclitaxel, carboplatin, and pembro, I felt so terrible. I was at nausea, and I felt weak, and I couldn't do anything. And of course, this was due to her adrenal insufficiency, but nobody had picked it up at the other hospital because they weren't really thinking about it. And we've seen this late too, when patients come in late and they're going to a different doctor than the one who treated them, as Rebecca, you pointed out.
Yes, and in fact, that's I would say a common characteristic of many of these side effects. They can happen after quite a lot of number of cycles, and even after stopping the treatment. I think that's a very important message to give, not just to those who manage these patients, but also then to those who are not so familiar with these treatments. Recently, we had a patient who had already stopped immunotherapy and had an important hepatitis. And if you don't think that it can be related to something that was stopped 2 months ago, then you may miss out on the proper management.
Yeah, I think that's so fascinating, because we diagnosed somebody with adrenal insufficiency also at another hospital where the insurance mandated she get her treatment there, through somebody who she was going to the wedding of the son of a friend of mine who's a physician who reported that this woman was doing terribly at 3 months and losing weight and unable to work. Turned out she had adrenal insufficiency, which she had the labs to support, but nobody had really understood it at her hospital. So, but one question for Zoe, one thing that we sometimes struggle with on the oncology side is we see these TSH less than 0.01 and a T4, T3 that are elevated. But so thyroiditis, essentially hyperthyroidism, and sort of we don't treat hyperthyroidism. So the question is, how worried should we be about that? How do we manage those labs when they come back? Hypothyroidism is a lot easier.
Yeah, so the hyperthyroid phase of what almost always will progress into overt and permanent hypothyroidism is really symptom driven. So if someone is very uncomfortable in that phase, we start beta blockade. But honestly, most patients tolerate it pretty well. I have had one case who was an older gentleman, not a breast cancer patient, obviously, but an older gentleman. He had cardiac issues. He had atrial fibrillation, and he ended up actually needing a thyroidectomy because we were unable to control his AFib with RVR with our traditional methods. We ended up starting all of the things for hyperthyroidism that we knew weren't likely to work in this setting, but just because we were trying to avoid surgery. So certainly if someone's super symptomatic or cannot tolerate that tachycardia, we have other approaches, but in general, we're able to just sit tight, treat that tremor and anxiety with beta blockade, and keep monitoring for the switch to hypothyroidism.
Do you commonly see
I would say
Graves' disease, for example? No.
Graves' disease itself is super uncommon. We're working on a case report of Graves' ophthalmopathy. I think if the hyperthyroid phase lasts greater than about 6 weeks, I'll start testing for the antibodies for Graves' disease, but I've never seen it besides this one case.
Sorry, Rebecca,
No. I was just saying I've had quite a few patients with thyroid dysfunction, and I would agree. I would sort of say we just kind of monitor them, but nobody's really needed treatment for hyperthyroidism. It really does seem to taper off quite quickly. And I think when do you start initiating therapy in hypo phase? And that I find varies quite a bit. And I was actually, one thing I wanted to ask the panel is that, quite a few patients take probiotics and PPIs and antibiotics and all those kind of things. And one of the things I've become more sort of attuned to talking to my colleagues who give a lot more IO is that I always forget to ask if patients take these things. Do you actively tell your patients don't take it? Because we should. I mean, all the data shows that. Just curious what you guys are doing.
I think that we don't give antibiotics lightly anyway. So I was really interested in those reports that suggested that patients might have more complications if they took antibiotics, or that IO might not work as well. There's a whole bunch of data out there, but this is all like, does coffee cause cancer, which I saw another Medscape actually alert in my thing about more data on this area. But I think we have to be cautious about this and use antibiotics judiciously. For probiotics, it's an interesting question. I mean, I think that there's enough data suggesting that they don't do very much, that it's reasonable to tell patients not to take them during treatment. But I wish, we had harder data on it. I'm not, I just can only inform patients and let them know. But if somebody has an infection, I think we should treat them with antibiotics. And if somebody's on steroids for a long time, I give them whatever it's called now, in my day, PCP prophylaxis, but BJP, I think, prophylaxis with Bactrim, or, a sulfa type drug, or a atovaquone in sulfa allergic patients. And that's, of course, really important too, because we don't want to cause other issues. But I do think this, high degree of suspicion is important. Two small points we've learned about is one is that if you are treating somebody who's profoundly hypothyroid, you do want to have some kind of a recent cortisol, because you can really create a lot of problems if you replace the thyroid and somebody's low on their cortisol ability to produce cortisol, which Zoe can speak to. And then I had another patient who she got immunotherapy, very complicated patient who presented with dermatomyositis and acanthosis nigricans and new diabetes and a triple negative stage 2B cancer, right? So She had a great response to neoadjuvant therapy, and then she had a little bit of residual disease, so she's going to go to radiation before we talked about capecitabine. So she goes to radiation, she gets her mapping scan, and he calls me up and he says, "I'm really sorry, but I'm seeing all these lytic bone lesions and lymph nodes, mediastinal adenopathy." So I do a PET CT, and it does show lytic bone lesions and FTG avid adenopathy. And so we biopsied the bone, and it was sarcoid. It was non-caseating granulomas. So then I did talk to rheumatology. They were like, "Oh, you have to treat it," but she's asymptomatic. And we waited a while, and it all went away. Really fascinating. And so did her dermatomyositis, by the way. But it just shows you that this is a really weird world we're living in now. We have to be very suspicious for odd things, including non-endocrine toxicities.
There are some situations where, particularly close to surgery, where there is this prophylaxis with antibiotics. So do you discourage that, or do you let surgeons do as per clinical practice?
We don't. I don't know, Rebecca, what do you do?
No, we don't. I mean, I think all of these things are, you have to give prophylaxis for surgery. There's just no question. I think one dose and en route and is absolutely fine. So yeah, we don't.
Me too. I just wanted to clarify that, because
that's a really
I don't
good
want
thing.
I don't want people to go to the other
stop you.
extreme.
No, I think the PPI question though is something really interesting though, because I
PPI
think there
is
are a lot of drugs. Yeah, I think we really underestimate, because it's in Singapore and in Canada, it's not over the counter, but in the US, it's, and I think a lot of other parts of the world, you can get PPIs, like you can, candy. So I think that it is something that I think we underestimate, but can decrease effectiveness of certain drugs.
It's an interesting question, because we do use PPIs a lot, because we know that gastritis contributes to nausea from our treatments. And so that's a question. What are you doing now for those patients if you're not wanting to give a PPI?
You can go back to
I think
ranitidine, right? Or cimetidine.
Exactly. Famotidine, or even, a lot of them actually have what I call functional dyspepsia, where, even with, a PPI, they still have side effects because they have functional dyspepsia. So I think Gaviscon or oral agents actually are very helpful in combination with famotidine or ranitidine. I think they can help quite a bit.
That's an interesting question. One big question that comes up for us a lot, I'd love your guys' opinions on, is when can you retreat? So you have these patients you really want to give the checkpoint inhibitor. You always have to balance, the potential benefits, if somebody's not responding, et cetera. But if you really want to give the checkpoint inhibitor, when do you hold for an immune toxicity? Like, do you hold for endocrine toxicities? And if you do, which ones? And when would you consider retreatment?
So it's been really interesting, because I think we all kind of have these general rules. I think with someone who had quite profound pneumonitis or colitis, I'm really inclined not to want to challenge. I think more recently, there was some data looking at % success in rechallenging. I think it's considerably less for people that have pneumonitis or colitis. And I think the challenge there is you also have a lot more challenges in terms of etiology that make it hard to know, was it the IO in the first place? But I would say I sort of would go through thyroid function. They're going to end up thyroid dysfunction anyway. So I continue with the immunotherapy for thyroid dysfunction. Adrenal insufficiency, thankfully, I have really had one case. And I would say the only other thing is I find some of the toxicities, like skin toxicity, sometimes people need a break. They just, they're not severe, but they're getting irritating, and they've got long, duration of treatment. Like, you've got those great success stories of, many years. It's the adjuvant patients that I'm finding a little bit more challenging. Like, we know that in the adjuvant maintenance phase, patients do better, meaning they have less toxicity. But I had a patient recently who just had non-specific fatigue, which we, our endocrinologists can tell us about. This non-specific fatigue, was it their surgery? Was it their recon? Was it 6 months of chemo before their surgery? But they're just not themselves, despite exercise, despite all the healthy living, supportive things that they're doing. And I had this patient, she just had gastritis, and she had this non-specific GI stuff. So I was convinced she was adrenally insufficient. Her biochem was off. And then I decided I just couldn't get her to feel better. And I gave her a break, and I put her on steroids, and she was like a new woman. And, I've gradually, I gave her sort of a 4-week, fairly short course taper, re-challenged her, and she got a lot more rash, a little bit of fatigue, but she got on top of the exercise regimen. Derm is following her closely and giving her tons of topicals, and she seems to be managing okay. But I think this is one, I mean, I guess all our patients are like this, but the journey is so different for every patient. And I think it's having us have to monitor that patient closely along with our specialists that can guide us as well.
Yeah, I had a patient come in with an eosinophil. All of a sudden, like she said, she had abdominal pain, and she came in and we checked her labs, and we had to come back 2 days later. 2 days later, her eosinophils were 10,000. It's like,
Wow.
well, I don't need a biopsy in this case. I think I can go ahead and treat. Anyway, she did get better. So it is fascinating. We've had the same kind of situation there. And so, Zoe, do you think it's safe to treat through hypothyroidism, hyperthyroidism, and adrenal insufficiency? And is there something different we should do with diabetes? We've seen 2 patients now with type 1 diabetes.
Yeah, for all of the endocrine glands, somewhat unique to other IREEs, like once it's started, we think the gland is gone or on the way to being gone. And so we don't see any benefit in terms of the IREE response from holding therapy. So for adrenal insufficiency and thyroid disease, as long as the patient is stable enough, I say go ahead with it. And really the same for diabetes diagnoses. I mean, if someone's in DKA and they're admitted, you're going to have a treatment delay most likely because they're sick enough for that. But if we're able to catch it early enough that we're managing as an outpatient, I am usually, well, we can just go straight through without missing any doses. I think it'll be interesting as we continue to collect cases to see if there's any situations where holding therapy might help with the gland remaining intact in some ways, but at this point we don't think there's any point to holding therapy. And then the exciting thing, particularly with thyroid, but with hypophysitis and with diabetes as well, is that there's potentially this silver lining that it's actually a marker of treatment response. And of course you have some survival bias, but particularly with thyroid disease, it happens usually so quickly in treatment, like people haven't even had their restaging scans. And so we can say pretty clearly that it's associated with response and across cancer types.
So what is your experience with liver toxicity? So in terms of re-challenging, so let's say you have an hepatitis grade 3, would you re-challenge Hope, Rebecca?
So, when we've seen this, we've seen patients where, we were like, oh, the enzymes are like, 110, for your AST or ALT. And then the issue is, they come in a week or 2 later with an enzyme of 800. In those patients, we don't re-challenge. And, it can be really challenging. I will see that, I will definitely think that we see that there's more immune toxicity in patients who we treat in the early stage setting than in patients we treat in the metastatic setting, probably because of the immune system being intact or other issues that we don't understand as well, because it's not just obviously PD-L1 expression, since we don't test for it in early and we do in late. But there's something else going on because we're treating these patients in the first line setting. But I will say that unless I didn't really know it was immune toxicity and it's only grade 2, I don't re-challenge just because it's so dramatic. What do you do, Rebecca?
Yeah, I'd have to agree with you. First you have to figure out what the cause is. And I think in the metastatic context, it's a lot less clear. In the early breast cancer context, it's a lot clearer. So that's been, I would say, my bigger challenge is just making sure, last week I actually had a patient normal liver function test, and then it was 500 and she looked so clinically well. I was like, is this IO? What's going on? Anyway, on further discussion, she was taking some multivites given by a friend. And she's like, oh no, they're all natural. And I said, stop them, get a scan, get your blood work. And then a week later, her LFTs were trending down to 50% what they had been. And so I think, in general, I would say if you have a sudden picture of transaminitis where you don't have an etiology, I'm unlikely to sort of re-challenge. I just think the GI, the lung, those are 2 things that I think are a little bit more challenging and potentially life-threatening. And I think the other thing that's really curious is, we really don't know how often you have to treat. I don't think you need to treat as long as the studies would suggest. There's great data by one of my colleagues, Chris Booth, who's actually looking at that. And so I think as Hope you were saying, we learn more about early versus late when the immune system is more intact and you have less immune escape. That's why potentially you're seeing these sort of sudden flares, right?
Yeah, I wanted to highlight just that when deciding to re-challenge or not, to have a look at the risk initial risk that made you go through with, I'm speaking about the early setting. So the initial risk for prescribing immunotherapy, as well as the response to surgery. And that may help you decide to re-challenge or not. In the metastatic setting, that's a different situation, since they will not be cured. But I think, again, this, as we always do in oncology, the balance between quantity and quality of life in the metastatic setting is indispensable, and not to forget that in the early setting, despite being triple negative, they are still potentially curable cancers, and we certainly do not want the patient to die because of the treatment. So this balance is fundamental. Perhaps one last question.
I just want to say that your point is really, really, really important, that the differentiating factors there. And early, I would say I rarely re-challenge, except for in thyroid dysfunction. As you said, because these patients are potentially curable, we even don't know how long we even need to treat. And it may even be, just a few cycles that's actually a benefit. So I think this is a really important point to anybody who's listening.
Yeah, I mean, adrenal insufficiency, we do treat through, as well as thyroid. I think this question of whether or not people need, ongoing checkpoint inhibitor after surgery, if they get a PCR, is so incredibly important. And hopefully in the next few years, we'll answer that question. But in the meantime, there's a lot of patients we're treating. So I agree with you. We should have in those patients a low threshold to stop in patients who get immune toxicity. And, hopefully we'll be able to figure this out. And, combination immune therapies, when you're giving them in clinical trial settings or whatever, these are patients who need to be monitored even more closely.
Perhaps in our last minutes, do you want to tackle some of the cardiac side effects?
Or pulmonary.
Or pulmonary, so the two that we have not mentioned yet.
So I haven't seen the cardiac toxicities, although I think we had one case that did very well, mild in I-SPY 2. I haven't seen them otherwise, but I have seen pulmonary toxicity, and it's like a big surprise. The patient comes in coughing or saying, I'm short of breath. And the issue is that our patients are all a little bit short of breath on chemo, even in the early stage setting, because they get anemic, they're fatigued, they give them steroids that make their muscles weak. But you really have to have a very low threshold for getting CT non-contrast and look and see what's going on, because this can really explode to be very serious, and it can take 6 months or longer to get them off steroids. It can impact their ability to go to surgery. We just recently had a patient hospitalized for 6 weeks with pneumonitis in the early stage setting. We don't even know which patients are at risk. I have to say, all of my patients have been, the 2 patients I've had who had very serious ILD have been older, but that's by no means seen in the trials. And my colleague had one patient who was quite a bit younger, and in that setting, we don't re-challenge. But Rebecca, you've seen some cardiac toxicity.
Just one breast cancer patient. Because of it, we had a longer dialogue about it. I think fortunately, compared to when we trained, we can get echoes much more readily, like in the emergency. And so I think one of the things that I think is a real challenge is someone presents with shortness of breath. It could be cardiac, it could be lung. And I think until proven otherwise, you get an echo and you get CT imaging and you move quickly. I think that's the key thing that in this particular situation is that you really can't underestimate how much the different organs interact. And, it could be even both, to be honest. So I think the key thing was, people thought it was pulmonary, but it was actually cardiac. And, we haven't talked about rheumatology today, but, let's be honest, our colleagues who treat other tumors have really had to engage our rheumatology colleagues, because there's a lot of drugs that they use that are used in sort of a patient who's having cardiac related immune checkpoint inhibition toxicity. And so this forced me to learn a little bit about some of the drugs that have been used. And so again, don't forget about your rheumatology. So I always find, dermatology, respirology, endocrinology are the top 3, but I would say GI is really as well. And so we have really learned to refer, even like low probability cases. So they just get used to seeing what these patients look like. And they respond very nicely to us, just sort of focusing on one person within each department who sees our patients.
Yeah, and then sometimes our patients do have immune toxicities that thankfully I've only had one ever that require more than just steroids. And in that case, we desperately need our colleagues to help us with that, in particular, all of our subspecialists.
And I think the cardiologist is probably one of the most important to have experience with immunotherapy patients, because, you know, myocarditis is not common to begin with. And so we don't know how to treat it as well as, you know, the endocrine diseases where we might have slightly different practices, but we know these drugs really well. They're using really alternative treatment, really different treatments than you would normally think about. So having someone with experience that you can call there seems very critical.
Yeah, I agree. I I didn't see in one of my patients, but I saw in a referral after the first cycle, severe myocarditis. So it can happen.
Wow.
And
That's amazing.
we need really to be attentive and have our let's say referral group of all the needed specialties. So I think if you agree that we have covered most of the side effects, and I think we have emphasized throughout our discussion the importance of multidisciplinary discussion and care, and of really not being afraid to refer, even if it's for a low symptomatic patient, because it's better to detect earlier, to treat earlier, manage properly, and as we already discussed in the latest minutes, we may be able to re-challenge, not all the time, but we may be able to re-challenge. So I think I would just thank everyone for joining us in this panel, and thank everyone for listening. Thank you.
Thank you.
Thank you.
Thank you.